Good morning from New York. Anywhere in the world you may be during this great endovascular case webcast we're about to do from the Mount Sinai Hospital Cardiovascular Catheterization Laboratories in association with the American College of Cardiology. This is a great week as it is just a few days before the annual scientific session conference of the American College of Cardiology. We hope to see everyone in DC, Washington DC Convention Center from this Saturday, Sunday and Monday of this week. During that conference, we're going to have live case transmissions from the cardiac catheterization laboratories of Mount Sinai Hospital on both Saturday and Sunday afternoon. Coming back to the webcast of today, endovascular cases, let me just, before we go to the laboratory, let me just remind everybody that the next one, there's a slight change. Instead of the fourth week of April, we're going to have the webcast on the 16th of April at the same time, 8 a.m. Eastern Standard Time, or the same time that you're watching today anywhere you are around the world. I'd like to also let everyone know that in addition to the live portion of the webcast, the website hosts two capabilities. One is to send a question. You can find it on the browser at the top, and I will be happy to read those questions and address them in association, obviously, with the operators as well. And in addition, you could view any previous case that was done under the archives section of the website. And obviously, you will be able to see even the case of today after its completion. It's going to be uploaded in 2 days in the same website at the archives section. And also, if you want to watch coronary cases, you can go to ccclivecases.org. And if you'd like to watch controversies in clinical cardiology, you could go to heart-talks.org. And several of these, the coronary case as well as this case, obviously are also available from cardiosource.org, which is the website of the ACC, the American College of Cardiology. Without further delay, we have a great case of a superficial femoral artery revascularization. Let's connect to the cath labs. Dr. PK and co-workers we will describe in detail. Good morning.
Good morning, George. Thank you so much. You know, we're happy to welcome all of you from wherever you're watching to really join us and really participate in this very interesting case. You know, I'm thrilled today to have a good friend of ours, Dr. Mark Burkett, who is the Chief of Cardiovascular Services at the University of Toledo Medical Center in Ohio. He was kind enough to fly in last night, take time out of his busy schedule to share his thoughts on us. Welcome, Mark, and thank you so much for coming.
Thank you. It's a privilege.
I'd like to introduce our team as always. We have Ray Lascano, our interventional nurse practitioner, Dr. Jose Wiley, our interventional cardiologist and associate director of endovascular services, Surabhi, our interventional fellow, Elizabeth, our nurse, and Ricky Ricardo, our tech. So, you know, without further ado, I'm going to ask Ray to go ahead and present this case. Ray, could you present this case?
Absolutely. Good morning, everybody. So this is a very interesting case. It's a 60-year-old male patient with complaints of left calf pain, typical claudication at rest and on exertion, Fontaine 2B. His past medical history is hypertension, dyslipidemia. Medication are aspirin, clopidogrel, amlodipine, lisinopril, simvastatin, and cilostazol. Social history is he's an ex-smoker, no alcohol or IVDA. Vitals are as stated. Peripheral pulses the Doppler DPPT bilaterally with no skin breakdown or tenderness. Resting ABI showed 0.80 on the right and 0.65 on the left of his lower extremities. Prior peripheral angiogram showed borderline obstructive disease of the right common femoral artery, popliteal artery with significant stenosis of the proximal right anterior tibial and distal posterior tibial artery, significant stenosis in the left external iliac artery, status post successful stent placement, chronic total occlusion of the mid-left SFA with significant calcification and obstructive disease, the left anterior tibial artery. Patient currently is planned for endovascular intervention of the long segment calcified SFA of the chronic total occlusion.
I want to just make a correction. There's a little typo there. It says claudication at rest, which is obviously a misnomer. So obviously it's not at rest. It's a Fontaine 2B.
Yep.
I just want to go over the angiogram for Dr. Burkett, for Dr. Wiley, and everyone else. Since we had a prior angiogram when we did this, what we normally do is obviously fix inflow disease. So we found the iliac and we fixed the iliac stent. So here's your moderate diffuse common femoral disease. We didn't do an iliac shot. It was a really simple up and over arch kind of thing that we went up and over. But I wanted to show this. When you have a prior stent, to all of you out there watching, I think it's very important to really, actually you don't have to cine it the way I did, but to really watch your sheath go through that properly, because it's very easy for the edge of the sheath to get caught in a stent strut and spoil the stent. So what we did here, Dr. Burkett, was we improved the inflow. We watched him. He did have minimal improvement of his symptoms. We were hoping that would be enough. And then since he did not have full improvement, his referring called us back and asked us to see whether we can go ahead and revascularize this. So as you can see here, you have a patent profunda with some diffuse disease. You have a superficial femoral artery, which is occluded again with some diffuse disease proximally, but occlusion, I guess, in the middle, the proximal 1/3 of the vessel. Distal, you can see the profunda robustly filling the distal SFA / above knee popliteal, or the SFA in the adductor canal, with some diffuse disease. And then below the knee, as we had talked about earlier, we didn't give much dye, but we gave a lot, enough dye right now to really see it well, so we can really read the angiogram a lot better to you. You can see that you have some posterior tibial disease, you have some perineal disease which comes back, and then you have an anterior tibial also which is diseased, which went back, and then you can see down at the level of the foot, you do have 3-vessel runoff into the foot. We'll see in a second, with the posterior tibial, the perineal, and the dorsalis pedis running into the foot. So, I'd like to just kind of stop here and just talk about this. I just want to say the reason we're presenting this, as most of you know, I think it was January or February, we attempted a very calcific SFA with Dr. Ferries, who was our guest at the time, and we failed. So we wanted to show you one that we can succeed, and we hope we can. As we know, with all these kind of things, anything can happen, and we feel that this is favorable. And I just wanted to ask Dr. Burkett his thoughts and what his approach would be, and then we could share our thoughts with you.
Yeah, well, I think this is really a great teaching case, PK, and there are a number of things that you've already mentioned that I think are really instructive. One is, obviously, when you have iliac disease and SFA disease, if you can get a good result on the iliac and get resolution of symptoms, you're done. And so really staging this in 2 separate procedures, I think, makes a lot of sense. The other thing I noticed is you used a self-expanding stent in the iliac in an area where the vessel can bend. When people really flex their hip, if you've used a self-expanding stent, then it has the capacity to move with that vessel and flex with the vessel. As far as this lesion is concerned, I think it's clearly a long segment occlusion. But in addition to that, you can see that even where the vessel is open, there's quite a bit of plaque disease, quite a bit of luminal compromise. So I think one of the decision points as the case unfolds is, what do you do about that, both above and distal to the occlusion? You can see on the angiogram that it looked like there was a critical stenosis in the adductor canal region, and then you see kind of faint opacification more proximally. I think as the case unfolds, we'll kind of get a better feel for what's really underneath. This would be one where I think I'd try to go straight through, stay within the lumen, just to keep the options open.
Right. Well, Jose, do you want to comment on the resting ABIs being so low? Because, I mean, one of the things that I think it's important for others to understand when they're involved in these cases is the effect of multi-level disease on this resting ABI.
Yeah, I think that the fact that the ABI is so low demonstrates why the patient is still symptomatic. Even though the iliac was open, he still has at least claudication with walking less than 200 feet, which is what meters what defines a Fontaine Class 2B claudication. So I think that's the reason why he's still compromised. And it's that SFA that even though there's robust collateralization, it's still not enough to.
And I think Mark, 0.6 is one of those scary resting ABIs, especially at rest, as you know. So I think here it demonstrates to everyone out there that you have the multi-level disease. Like if you have iliac iliac with SFA, with infrapopliteal, as you've seen here. Clearly, yes, you open the iliac. I'm sure if we repeat an ABI right now, it would probably be 0.75. Maybe I'm guessing that we didn't do one. Maybe we should have. It would give us an idea on what effect that iliac had on his resting ABI. And you can't expect the ABI to return to normal, maybe not, because of the infrapopliteal disease. Has that been your experience as well in terms of following these patients with ABIs? Do you follow them with ABIs or symptoms post-revascularization?
We actually use ABIs and symptoms, and periodic intervals we'll do a femoral popliteal duplex.
Gotcha.
So all of those kind of work together to help with the follow-up.
Great. I just want to tell Dr. Burkett our plan for the case, and we'll ask him to comment on his. So I just want the audience to look at the angiogram. And remember when we did the CTO case, we talked about the different types of beaks and caps in the SFA in the lecture afterwards. And you can see here, right here, you have an SFA that's relatively favorable because you have a little bit of a beaking to that occlusive proximal cap. However, what's unfavorable here is that you have a branch. So at least our plan is, and I'm curious to see what Dr. Burkett would think, and I've magged up here for the angio, is to go ahead with with a shaped catheter that you see here. And our hope with the shaped catheter is to avoid that collateral and then try to go down. And we're using a device which is it's a device which is basically an intraluminal type device which finds fenestrations with rotation of the catheter. It's hard for me to explain, but it's called the Viance device, and it's the only one of its kind. So I'm going to go ahead and say the name in the ACC website because there's no other one that's really like this particular device. And so what we're going to do is we're going to use this and start to work as Dr. Burkett goes ahead and talks about what he would do to approach this.
So typically on a case like this, I would first cross over and just get contralateral access with a catheter like a Uniflush, something that gets me contralateral. Then I would switch out for a 6 French sheath. Usually I'd use a hydrophilic 6 French sheath, and that's kind of the basis from which I'll work. And then through that, I'll put an end hole catheter. There are a variety that are available on the market right now. And then I would probably start out with a straight 035 hydrophilic wire initially, realizing that there's a very high chance that that's going to immediately pop into that collateral channel. If it pops into the collateral channel, then I'd pull that wire and probably use an angled glide and see if I could direct that into the occluded portion.
So you can see here what we're doing is rotating. And as you saw in our presentation, we did feel it was calcified. Can you advance the wire a little bit, Jose? And you want to get the wire to the tip, but not outside of it. There, right there, perfect. To give yourself a little bit more support. That's fine. That's great, Jose. And all you're going to do is torque this. And I'd like to demonstrate it because it does work in our hands quite a few times. I don't want to say that this is the all end-all device that works. I think there's multiple other devices. See, when it starts to buckle like that, we don't like it. We pull it back and try to redirect it or not put as much pressure. And the whole point is to keep spinning it. See how it just broke through there, guys? So that's kind of like the puncture of the cap that you want. So you have to be very cognizant, at least with this particular device, to do this. And I think the key is not to allow it to buckle. Now, we may still be going wrong, but I've achieved what I wanted is to break the cap without doing this. And I'm just going to, again, for purposes of teaching, demonstrate where we're heading in the channel here, so this way we can discuss. So, Mark, if you're going to use a wire technique, you said a straight wire, right?
Yeah, usually I'll try to pop through the cap with a straight wire, but realizing that, especially with this big collateral, it may not stay on course.
So what would you do? What would you tell everyone, Mark, in the situation where you do veer off course? What would your approach be at that stage? Say you start to veer off course with this particular approach.
Well, first of all, I think that the odds of veering off course are very high with a collateral channel like that. So at some point, then you have to add curve, and you can do that either with your catheter or with your wire. So you could switch out from a straight simple catheter at the beginning of the case, something like a Seeker or something along those lines. And then to get some directionality, you could simply switch to something like a multi-purpose or a CXI.
It seems to be working nicely. I just follow something that we can imagine as the outline of the vessel. So most likely has stayed in.
Yeah, that really looks, just by the way that the tip is moving, it looks like it stayed within the true lumen.
So Mark, I mean, tell us some tips. So what should the audience out there do? Okay, in their lab, they may not have a specialty catheter for this type of crossing, right? So you're left with a directional catheter and a glide wire. So the key here, like you suggested, was to stay away from that collateral, which you're able to do. And then how close do you have to keep your guiding catheter next to the wire? Is there any rules on that? Is there any thoughts on that?
Great point. Yeah, you really, the tip of most of the wires is not all that supportive to pop through this cap. And so you're going to have to bring, let's say you chose a multi-purpose catheter, which is available in just about any lab. In this projection, you can get that tip away from the collateral, and I would have it within several millimeters of the target, and then you could bring a straight wire down into that, and that's going to go right into the cap.
So PK, you're advancing the catheter over this device?
Yeah, exactly what Dr. Burkett said is to provide a little bit more support. Obviously, we could be a little bit closer, but it's moving freely here, George. And I'm just going to have Dr. Wiley, for teaching purposes, just give a little roadmap for us to have a target. I know that everyone in this room feels that we're heading in the right way, as do I. So I think that let's give us a target to head towards. And you can see here that hopefully there it is. So we're pretty close, and it looks like we may be slightly off. And I think this is the area where you want to really be careful with this wire. So Mark, we've transversed this zone, and Jose, you also, and you get to the cap. And this is interesting here, Dr. Burkett, because you have this long segment, diffusely diseased area. I'm sure the whole vessel is diseased, but really angiographically severely diseased area. And then you have a distal reconstitution which looks healthier,
right.
And clearly you have a large collateral. So in your idea of re-entry, say you're doing a loop wire technique, or what you start off as an intraluminal technique turns into a loop wire technique. Do you have a target in which you want to enter the distal vessel? I mean, what are the parameters you set for yourself before you pull a re-entry device?
Well, what I'd like to do is you can see that just beyond the tip of where you're working there, maybe 2 centimeters, the lumen starts to reconstitute.
Yes.
I would love to be able to enter at that point, because I'm pretty confident that if you can get in there, then you can stay true luminal all the way down to that terminal area where it's really tight, which I suspect was probably the original culprit.
Right.
If we could turn the clock back, I bet that's where everything started.
And is that because of the collateral that you say that, or what?
Just because that is the typical location where the SFA usually goes bad first, is right there. I mean, that's the adductor canal region right in there.
I think you're in it, man.
And I would bet that's where it all got started.
So I'm just going to advance the wire. This is something that we started doing recently. I just want to make sure that just to see where we are and how it goes. It looks to be, but it's not moving quite like it's intraluminal. So I'm going to just keep going slowly here. I mean, we could switch out for a glide type wire and then decide, like a fielder, maybe a coronary fielder. But we can definitely IVUS this to see whether we are intraluminal. See, I don't know if we are, Jose. You see how that's kind of fighting us there a little bit?
I think there's still a diseased vessel there. I think we're going to know very soon.
I think they may be just diseased in the area. I think you're just going to go a little bit further. And
now we're definitely
from then on, it should go freely, and that could be a good.
It never really seemed to deviate.
There you go.
Yeah. So I think we're back through. So I think what we do here is now we'll get another wire that's a safer wire, and I always tend to switch wires. For those of you at home, what we do is we switch out to a safer wire, whatever support wire you use and whatever support wire you have in your lab. We know the Confianza is an aggressive tip, and the reason we used this here was to give us a lot of support, and if we had to do some sort of distal re-entry techniques with the sharp tip, we have it available and save some time. So now I'm gonna do an IVUS since we are live, and I'd like to show how we are, whether we're intraluminal or not. And we have Dr. Burkett and Dr. Dangus, and we can talk a little bit about that. Can you set up an IVUS quickly, guys?
Yeah.
And what we'll do is, so Mark, I just want a couple of questions for you. So if you get to that distal tip, and you think you're intraluminal, but you try to advance the wire, and you're not in the right area. Do you have an algorithm of what are the steps that you do in order to break that distal cap? You transverse the body of the lesion. You're not too subintimal in your opinion, at least angiographically or by fluoroscopy. And now you're like, okay, I'm right here. What can I do to get back into that vessel?
Yeah, that's really a good teaching point. So if I've gotten, let's say that I'm about as far as you are right now, PK, and I'm clearly not in the true lumen, then what I'm going to do is back up a couple of centimeters and I'll take another swing at it. And this is where I'm going to start playing around with wires. So if I've been using a straight wire, I'll switch to, say, an angled glide or maybe an 18 hydrophilic wire. One of the things that you can do with an 18 hydrophilic also is you can kind of change the tip stiffness by trimming it back. Now that's off-label. There's nothing in the IFU that indicates that you can trim that back, but sometimes you need something which is hydrophilic and a little bit stiffer than what you typically get out of the box in order to maybe just penetrate through the false lumen that you've created.
So would you try a hydrophilic first or a stiff lumen first?
I would usually go hydrophilic first and see if I can get back into a different plane that'll take me right down into the true lumen at that cap.
And I think that's a great point to the audience at home, because I think, sometimes you have these micro channels that you can pop through with just a nice hydrophilic wire. So rather than go with a stiffer wire, which may continue your dissection plane down, if you're careful enough with a hydrophilic wire, you clearly can go ahead and do this.
Yeah.
I'm going to have Dr. Wiley just gently walk this out, and then we'll go ahead and we'll go ahead and do our IVUS.
I think an important point, PK, is not to get too aggressive with the wire or with the catheter if you think you're subintimal, because you're really compromising distal real estate with every move that you do more distally.
So when do you decide to pull out spend the extra money? We know, today's, especially yourself, and I'm going to ask you to comment on the fiscal aspects of what we do, but knowing especially your vast knowledge on this, when would you tell others, like, hey, you're in this is the time to pull out, or when is your algorithm when you say, I'm going to go with a re-entry device, which is obviously going to add some cost to your procedure?
Yeah, I'll probably try for maybe 5 minutes or so with a wire. We don't have a timer going and an absolute cutoff, but in general, you're going to know whether it's possible or not, say within about 5 minutes.
Right.
And then at that juncture, I think, I've heard Gary Ansel make a comment one time, which I think is really good. He said, before the case, I think a lot about expenses.
Right.
And during the case, I don't think about expenses, because you have to get the job done. So a re-entry catheter is about $2,400.
Right.
And so if you compare this case to one where all you did was put in a wire balloon and a stent, you've added the crossing catheter, which at a minimum is going to be about $115, and a re-entry device at $2,400.
Right.
And the hospital will not get a higher reimbursement for using those. So it comes right out of the hospital margin.
So, just to be clear on the capabilities of this catheter that crossed so nicely, actually, and so easily made it look like real easy this case, whereas it's not, perhaps, with other devices. Does it fit only 014 wire, or does it fit 018 wire inside?
Dr. Denkers, that's a great point. It comes in two different configurations, one for above the knee and one for below the knee. We've used both, and I think it really is quite effective, except you have to be cognizant of watching it very carefully, especially to not allow it to deviate from the track. And I think it's important for the operators to understand that there is a identified path to the SFA that you're following, and the rail, please. That you're not railing. Yep, thank you. Sure. That you want to be able to follow. And I think second, what Dr. Burkett said, regardless whether you use a wire or this catheter, if you can have a support catheter, it always helps you. So a support catheter is a great help to you in order to see it. And so therefore, what we're going to, I think those are the two tips that I can, impart on people.
There's an overforce system.
Okay, so I'm going to do this is a IVUS catheter, a vascular ultrasound catheter that we're just going to do a manual pullback. And I just want to comment, you guys, especially with your experience in IVUS, just to comment on what you think we are. So obviously we're inside the lumen here, distally, and I'm just going to pull back very slowly.
Ask him to take it off.
Yeah, just looked on a quick go-through as you were introducing that, PK. It looks like you stayed true lumen the whole way. And one of the other things which is really clear is that this vessel is diseased from stem to stern.
Yeah. There's a lot of plaque, and clearly in the middle of the vessel with a lot of plaque burden. We can see the...
So there's a little bit of what would you say, a dissection there, or what do you think about that? And here it's completely around the lumen, around the catheter.
Well, maybe a little bit in and out of the lumen at some points, but...
I think you're right, George. We are in and out. So you can see here pretty much the architecture of the vessel is intact.
Over here we're in, but perhaps towards the end we were a little bit out and then back in again.
Right. But over here, definitely the architecture of the vessel is quite good. And by IVUS, you have that branch coming up at the proximal cap, and you can tell pretty much where that proximal cap is. And as we get through the vessel here,
Well, it's interesting to see that the consistency of this plaque is not that much calcified. It's mostly fibrotic, and it has some calcium elements, but I don't see any major arc of calcium except when you go out to the adventitia. At least in this part, let's see proximally what's happening.
I think that's a really good point, and that has implications for what type of therapy is going to be best for this patient.
There's a lot of plaque in this vessel. Wow.
Yeah.
Let me see where we are, Jose. Off-road map. I was pulling back quite slow, but not that slow. As you can see, I'm way up here. Little test, guys, just to see where we are for the audience.
Yeah, we're seeing the IVUS, so we don't see your angio. So.
Right. So you can see here.
We're
so
very close.
We're still within the vessel, so we're still
within the vessel. So let's see the final one. That's a very interesting thing because that's where we.
Now it looks like we
had the.
Can we put on ChromaFlow here, guys?
Go live.
Go live and put on ChromaFlow, please.
Live on Chromo.
So which is interesting. So this is an occluded segment, and by IVUS mark, it looks like there is not, you should have flow in this particular vessel.
Right.
So I question whether we had some thrombus in the proximal area, and then now we're.
Yeah. Oh, okay.
Is that live, guys?
Yeah, it is live. We see minimal flow.
Minimal flow. Okay, agreed.
So maybe this means that we're just subintimal in that area.
Might be, exactly. Okay, that's the branch. So we had the branch coming, now we're in the main lumen. And exactly as Dr. Burkett was saying, look at the amount of plaque and how the angiogram can really mislead you. I mean, the angiogram, I guess looking at it, in my experience, I would say, okay, it's moderate diffuse disease, but no real, but look at the amount of plaque that you're dealing with.
There's tremendous plaque all over. It's great.
Look at that proximally as well, and then you're going to pop in, there it is proximally that we talked about. Now you're going to pop into there it is again. And then the common femoral should be coming here, and then we'll see the stent in a second. There's the common. So now that we've seen it, I think we're pretty convinced that we may be partially in, partially out. But the majority of the time we're in. I'm sorry, can you show me below so I don't lose my wire? Thank you. Oops. Great, so we've got plenty of purchase. So what would your therapies be here, Dr. Burkett, in terms of what you would like to do to this particular vessel? I can tell you our plan. Our plan is to go ahead and use a drug-coated stent here. As you know very well, we've got the availability of the drug-coated stent, and I'm just curious. I know you've done a lot of work with that stent, and have a lot of experience with that stent. What are your thoughts on how you would approach this? Say in two manners. One, if you didn't have the drug-coated stent in your lab, and two, if you did have the drug-coated stent in your lab, with the length of the lesion that you're dealing with.
Right. So it looks like the dimension of this is about 5.5, just by rough eyeball. I think we're getting some dimensions here, but I'd start out with just probably a 5 millimeter, 10 or 12 centimeter balloon. That's going to give me a lot of information about how this is going to behave. But I think the end strategy here, especially seeing minimal calcification, is going to be to go with the drug-coated stent. I think it's going to have sufficient support to do the job, and I think the TLR data would support its use.
So if somebody out there, is in their lab right now, they don't have a drug-coated stent, or for whatever reason it's not available. I'm sure Cook has made it quite available everywhere, but I'm saying there are labs out there who may not have it. Is there anything that you would do, knowing the data with long segment stenting, that you'd be worried about with TLR, or would you still say this is a case that you should stent?
Yeah, well, I don't think you're going to get a good result with just balloon alone. I mean, you might, but I highly doubt it. And I think some of the early data from the early randomized trials indicate that long-term patency is going to be better in lesions like this with stenting versus balloon angioplasty alone. There's going to be some people who would advocate atherectomy in this setting, especially since you were very careful with wire placement. I don't think you have to worry about getting outside the vessel with an atherectomy device. I'm just not convinced that the data really support a long-term durability with atherectomy that would be sufficient at this point.
I think this is a great discussion that Dr. Burkett just brought up, because I think this is something where you really are at a bind when you're out there. You're doing this and you're worried about the traditional teaching of long segment stenting, which we went over. The TLR data is not that good, but at the same time, I think this is where we're now in an era. The rail, please. Where you're fortunate enough to have a product or a device that's available to your patient that you can use. And the question there, Mark, is that I think if you're a purist out there and you're going to be sitting there saying, well, that's great, what Dr. Burkett and Dr. Christian is saying, I like it, but these lesion lengths that they're treating have not been studied in a randomized fashion, and they've been basically studied in a non-randomized fashion. So I was just wondering whether you could comment on some of the long lesion data.
Yeah. So if you look at the randomized trial, which had nearly 500 patients in it, and then you compare that to the registry data. So just to understand that trial, there was a randomized trial comparing conventional treatment to the paclitaxel-coated stent, and then there was a single-arm registry. And in the single-arm registry, they could use up to 4 stents. And when you take the curves on long-term outcomes, they're remarkably similar. And so I think it's one technology where it has really done well, even in longer lesions. I'd much rather have a randomized trial with longer lesions,
sure,
but that's not going to come anytime soon.
So that's a great point. So you do have data in these type of long segment that we're treating. Is there any information on the longest segment that they, or the longest length lesion that they treated in that particular cohort, Dr. Burkett?
Well, they did treat up to 4 stents, and that was 80 millimeter stents. So
right.
If you take out a centimeter for overlap, at each of those junctions, we're still looking at, like the high 20s, 28, 29 centimeter lesions
right.
for the high-end lesions.
So that's great. So any thoughts on the slotted stent design stent? Because I know that the superb data or the superb registry, or I should say the study, has been finished. I know it wasn't a randomized study, has been finished, and I know that they're yet to, publish it publicly. But what is your experience with that particular stent design and in these type of lesions?
So slotted tube versus woven wire, is that?
Exactly.
Yeah. So and that's one of the reasons why I think George's point about the lack of calcification in this lesion was so important. The fact that this is not heavily calcified means you really have the option of either one, I think. And some of the data with long-term patency with the woven nitinol stent, I think, are excellent. The primary patency has been really good. As you well know, it's a trickier stent to deploy.
Yeah.
So I think if you are not familiar with that stent, it's not something where you just want to pop it out of the box and try to throw it in. You really need to have the right feel for how that's being deployed.
So I think so here what we've done here, just for the audience to keep them up to us, you're up. What we did was we went up with an 014 balloon. Unfortunately, we're an 014 wire. The 035 balloon would not track. So now I've put an 014 balloon, which is a 4 millimeter balloon. I might have to do another dilatation. I'm just watching the balloon expansion, as Dr. Burkett said, and you could see here you probably had moderate disease in the proximal with a really tight occlusive segment in the mid.
Right.
And so you learned that. And the second thing, at least what I learned, and I welcome both Dr. Wiley and Dr. Burkett's thoughts here, and you too, Dr. Dangus, is that what I learned from this is, am I going to have trouble with stent expansion? Is that what you look at when you look at a balloon expansion, or what are the other things that you look at when you look at balloon expansion?
By the way, what's the exact dimension of the balloon?
40150.
40150, Dr. Dangus.
Oh, okay.
And go to nominal.
And we did not address given the absence of calcification, the length of the lesion, and the amount of plaque, we didn't address the possibility of using a filter.
That's a very good point.
Would that be a concern at all? I know if it was any atherectomy, of course, that would be a no-brainer. But even with a ballooning of such a long lesion, might that be a consideration or not so much?
Any thoughts?
Yeah, I think a great point, and as time goes on, we're using more and more distal protection in this application. I think clearly, as you pointed out, George, if there's any atherectomy, I would pull out a distal protection device. Also, I think the history is very important. This is a patient who's had pretty stable symptoms, which makes me think there is probably not fresh thrombus in here. Any question about fresh thrombus, I'd use a filter. Short of that, I think, he has, although there is tibial disease, he has 3 vessels that are all at least in part open. I think that gives us a little margin for minimal embolization. I'm not anticipating very much in this case, though.
Yeah, and I think, as Dr. Dangus knows, we have a pretty good algorithm here, Dr. Burkett. What we do is, as you said, our algorithm for filter use, which again is off-label, at least there's one FDA approved with an indication for calcific disease, but all the rest is currently not on label. But we do have an algorithm for using it, which is obviously obviously atherectomy and calcific lesions, any sort of atherectomy and calcific lesions, because we feel the potential for embolus is very high. Long segment SFA disease such as this with single vessel runoff, any sort of thrombotic lesions that Dr. Burkett was saying, and obviously any sort of in-stent where we're planning on doing off-label atherectomy, for whatever the reason may be, at the discretion of the operator, we go ahead and use a filter, because we find that these are the lesions that tend to have the highest risk of embolization. So therefore, I think in this particular case, Dr. Dangus, to answer your question, is it probably is not prudent at this stage to use a filter here. Go ahead. So the question here is, Dr. Berger, now that you had trouble with an 035, this is kind of a real world scenario. You got an 014 wire down, you're happy you're interluminal, you try to put a 014 balloon down. We unfortunately can't have every balloon on the shelf, so we don't have a 50014 balloon, so we went with a 40014. So prior to stenting this, since we did a measurement, and like you said, it was 5.5, the vessel size, and it tapers up, broadens up to a 6.0 approximately, would you at this stage re-balloon this in terms of a vessel preparation prior to putting a drug-eluting stent?
Well, I think if you put a drug-eluting stent in, you're going to be able to expand it at this point, so I don't think that's really necessary. At some point, you're obviously going to have to put in a larger balloon, and I think still undetermined is what's the proximal and distal therapy going to need to be.
Exactly.
And that's going to require a bigger balloon, to tell you.
So so in anticipation of putting a drug-eluting stent, would you go ahead and don't this with a what is it called, a larger balloon?
Yeah, I think I would, especially seeing what we're seeing right here, where we really are not getting flow in that central segment.
Right.
I'd probably put in a long 5 millimeter balloon.
Give me a 50150 balloon, guys.
And probably extend it a little bit beyond at least proximally.
Actually, give me a 50200 then. So George, I think that's a great point. This angiogram showed us a lot here. As you can see, you clearly, have a lot of recoil, and maybe, like you said, maybe a component of thrombus, especially in the middle. And I think here is when the operators who are doing this at home should watch out to make sure that the anticoagulation is adequate. So, right now we didn't talk about anticoagulation much, but we use a lot of bivalve-Rudin. As you know, safety data has been established in bivalve-Rudin. There's a randomized trial ongoing right now, which is just started. We're not yet part of it. We hope to be part of it with bivalve-Rudin versus heparin. So you could see here that at this stage, if you're using traditional heparin, you want to make sure that your anticoagulation strategies are perfect, and you want to make sure, check your ACT, and give additional heparin if you do need it, and be careful of that and be cognizant of that. So I think that's an important thing here. So the importance of, what do you think the role with drug-coated balloons would be here, Mark, once that's done?
Yeah, that's really a great point. And so if you look at the drug-coated balloon trial data, the results are great, but the lesion length is also pretty short. So typically we're talking about 7 centimeter lesions or so. Obviously you have something much longer here. So if you prepared I think one of the big unanswered questions with the drug-coated balloons is, if you had a lesion like this and you went to the effort of really preparing it so that you have an adequate balloon result, then is the drug coating, in addition to that, going to be sufficient to give you long-term durability? I think that's unanswered. Obviously, the advantage to that is if you can get away without leaving a stent, then in a patient like this, the chance of restenosis is high. It'd be great if the second intervention did not have to deal with the issue of in-stent restenosis, but just restenosis. So
that brings me to the next question, George. I'm sorry to interrupt. Is looking really into the future, Dr. Dangus, and Dr. Burkett, you know that in the coronaries we already are playing with bioabsorbable technology. So in this particular type of lesion, where you have obviously a great stent in the silver, the Cook stent, in the drug-coated stent, will there be a role for bioabsorbable, or would you worry about radial strength in this particular lesion?
I think yes and yes. So yeah, I would be concerned about radial strength, although this particular lesion is not all that challenging in terms of the need for radial strength. But I think bioabsorbable would be a great option here, something that supports the vessel, lets it heal, and then goes away.
George, any thoughts on you?
Yeah, no, definitely would be, because again, we're going to convert a very long stented segment potentially. If you have a small problem of radial strength, you need at the second time to put much shorter stent, but clearly having a 200, 300 long stents in the SFA is clearly way more metal than needed, and the bioabsorbable will have a great role here. What I wanted to ask before is we're used to treat, particularly with the discussion of bioabsorbable, in the coronary area, we tend to do a lot of preparation and pre-dilation and very careful post-dilation. Any of these considerations in this particular stent we're planning to put, or in the slotted tube type of stent in the periphery, or not as much? I mean, what I'm saying is when you try to put a drug-eluting stent in this lesion, would you try to do mostly pre-dilation in order to limit the post-dilation, or that should not affect really the stent in your opinion?
What do you think, Dr. Burkett?
Well, I'm not. We would routinely post-dilate. It's very rare that we'll put a stent in this location, not post-dilate. Maybe the only scenario would be if we were concerned that we were trapping thrombus. And then with post-dilatation, we tend to be pretty aggressive, with the exception that after we have defined where the stent's going to go, we're not going to balloon aggressively outside of the stented area. Last thing we want is to have an edge dissection and then need to add 1 or 2 stents on 1 or 2 ends.
Now, just to comment on the slotted design, Dr. Burkett as well as Dr. Dangas, I think the slotted design stents, they are very, very particular that you prep the vessel well. And I think the reason is with the slotted design stents is it's such a non-compressible stent that if it doesn't go up to the size that it's meant to go, if it's a 5.5 stent that's supposed to go to a 5.5, what happens is the stent tends to elongate. I think you have a different set of problems with that particular stent than you would with, say, a drug-coated stent such as this. So therefore, I think that this particular stent here, I mean, we've got good balloon expansion with a 5.0. We know the margin where we want to hit it in terms of where we want to land it, and then I think we should go ahead and stent here, Dr. Burkett. What do you think? I mean, would you like go with a 6 here, make it a little bigger? What would you do?
Yeah, I probably would go with a 6.
Get a 60200, guys.
Yeah, and I think with the for the distal target, there was that little branch that kind of marked where the lumen got back to pretty much normal size. I'd probably position it maybe 5 millimeters, 10 millimeters into that segment.
Okay, so that's a great point for the audience out there. So what Dr. Burkett is saying is when you have that, when you want to find out where you're going to land the distal stent, you want to be a little bit into what's called angiographically normal. We know nothing is really normal in these vessels. Angiographically normal segment, and at least relatively normal, and then you want to give the drug a chance. Is that for edge restenosis, Dr. Burkett?
Yeah, I think if you try to drop it right at the edge of the angiographic lesion, there will be a stenosis. There's a higher chance of stenosis. But as your IVUS really showed very well, PK, there's clearly, I mean, you could track that IVUS down all the way to the tibial vessels, and I'm sure you'd see atheroma all the way down. So it's an imperfect fix, but it's kind of making the best result that we can given the anatomy.
So I'm just going to get this balloon down there. What I want to do is show everybody where I think it is. Okay, so this is a 200, guys, or 100?
200.
Okay, scene minus. I just want to show you this. So you can see here, if you look carefully at the distal part of the lesion, and I don't have a pointer, but you can see here that there's competitive flow by the collateral. We see right there, you see a little bit of competitive flow proximally. So that's because now you've actually got restored, antegrade flow in this vessel. So therefore, it's going to be harder for you to see that collateral, but you want to identify that competitive flow on your picture here, and then make sure that your balloon is slightly at that level, or maybe a little bit past it. So I'm just going to go slightly past that level and ask Dr. Wiley to go ahead and balloon this. Yep, which is right about there. Actually, hold on, Jose, I'm too far down. Forgive me. Right about there. Perfect. Go up there.
So PK, one of the things we haven't talked about, and as we talk about collateral channels, it's very germane. How about PTFE-coated stents?
That's a great question. The Vibrant data was published, again, non-randomized controlled fashion, but sorry about that. He has a little bit of pain, which Elizabeth will give him a little medication, as you know, when we go up with these balloons. Mark, I mean, our algorithm, I know Dr. Wiley and I and Dr. Dangas have been, enthused about using, these stents in certain subsets. The majority of the time, we're a the PI of the trial from UCLA, was saying that it didn't seem to matter in the trial. But in our experience with the older Vibonds, and I think we're a little bit maybe old-fashioned in that approach, we like to have at least 2 vessel runoff prior to putting a Vibond stent in. And so therefore, also, if you look at the patency compared to the drug-coated stent data, I think it's much better in the drug-coated stent. I don't know any opinions on that?
Yeah, well, I think it's one of the viable options that we have now, and it's one of the things that makes treating the SFA so difficult, because now we have more better options than we had in the past. The nice thing about PTFE is it creates a physical barrier to restenosis, which theoretically is great. Obviously, what you have to be cognizant of is that placement may really interfere with collateral flow down the road. And so if you're crossing key collaterals, then that could really come back to haunt you if there is loss of patency.
Well, one of the things we worry about is turning a claudican. I know if we get restenosis with an SFA stent, they come back as a claudican. Rarely, like you said, if we cut off all these little collaterals that we get in the SFA, they could come back with a cold foot. And I think that it's really the approach of the doctor. I don't think there's definitely no head-to-head data, but there's really no other clear data for us at this stage to make a decision. But in general, what we do is, there we got the dissection there, and there's that collateral that we talked about distal.
Yep.
So I think it's pretty good here.
Now we see a much better film.
Yeah.
So how would you size these stents, Dr. Burkett?
So was that a 6 balloon that you just used?
I just did.
Yeah. So I'd look again at the IVUS, and do we have an IVUS dimension?
We have 5.5 distally, 6.5 proximally.
Okay. So I would probably go with a 6-100.
Okay. Get us a 6-100, please.
I think you could make a case for a 7-100. I don't think that'd be a problem, but I'd probably go with a 6-100.
So what we're going to do here is identify the target area distally. So we know that the stent lengths that these particular stents come in are going to be in either, I think, 100 or 80 at this stage. So therefore, you want to see where you're going to land this particular stent. And I think the question is, that's why I did this picture here. So would you land it past that collateral because you have that disease, Dr. Burkett, or would you go all the way to the above knee area there?
I think I would probably go, you can see where the collateral comes off to the left. I would probably go through that disease segment just below that.
Okay, so, and this is a great point. I think this is a great teaching case because, we didn't traumatize that area. Remember, I moved my table up in order to take the picture of this area. So we've never been there with a balloon, and we know we were intraluminal with the re-entry device. So right now we're going to go with this particular stent, and I just want to place it. And I'm lucky here. I'm fortunate. I have Dr. Dangus, Dr. Burkett, Dr. Wiley here to advise me on what I should be stenting. But I'd like everybody at home to take the take-home message of what we suggest on how to stent these vessels. So at this stage here, I mean, my worry, and I guess it may be old school again in the way I was trained, is that the above knee pop, is a particular area where it's favorable for bypass grafting, it's favorable for future therapies. I may not want to disturb this with a foreign object such as a metallic stent. But the point becomes is that a factor you think about, Dr. Burkett, when you do these cases, future therapies for this particular area, or do you feel like I'm going to go sort of the coronary teaching? And George, I welcome your thoughts too, from normal to normal.
Yeah, another really good point. So actually, this came up in a discussion just about a week ago. Gary Ansel and I were involved with that very question, and talking about if this area is diseased enough that we're thinking about putting a stent in it, it's probably not a good place to put in a distal anastomosis for a bypass graft. So it makes sense. I would say if we go right about to the cortex of the bone we're going to cover that area, which is probably too diseased to accept a bypass graft.
Right there.
I suppose you could endarterectomize it and put a graft in, but I think even with this location, you've got plenty of landing zone if that's ever required.
And the new meta-analysis that was published, I know Dr. Light and I spoke about it on the phone, was that clearly the below knee pop is also become a very favorable area for bypass. So, it gives us, especially with this newer technology, not to get so worried about the above knee pop as the only bypass option. If you have a healthy below knee area where you have a very, very competent surgeon to be able to hit that landing zone, I think you're fine. And I just want to mag up here to show you how the stent deploys. So it has a safety latch that I took off, and now I'm just going to go ahead and deploy it. It takes a little bit of effort to make it come out of its shell. So you can see here we're just trying to get it to come out of the shell here. There it is.
So this is a stiff deployment, and I think the manufacturer clearly recognizes that, and they're dealing with that. One of the things that I've found very helpful with the Zilver PTX is to have two hands really close together. I'm not sure if my hands are on the screen here, but if I hold my hands just like this as I start to deploy it, then I have a lot more control, and I can kind of pull that outer sheath towards the mandrel. But this, you've nailed that exactly where you wanted it, PK.
Well, yeah, I think that's the key here. Exactly what you're saying. I think it's important for everybody out there to understand the stiffness of this stent and the limitations. As they're improving their technology with every iteration of it, they are clearly going to go ahead and make it better. But clearly, you have the advantage of the drug coating, and the technique is important here, as you saw. The key now is to make sure now we're going to talk a little bit about the overlap, and I asked Dr. Wiley. Dr. Wiley, what's your algorithm in the overlap of these stents? Can I have another, give me a 70100 now?
Yeah, I want to minimize it as much as possible. Perhaps 1 centimeter would be more than enough. I don't want to have too much double layer of stents.
So when you say 1 centimeter, you mean 10 millimeter overlap? Is that what you're saying?
Perhaps less. I just want to make sure that I have some overlap, but try to minimize it as much as possible, just to decrease restenosis.
Dr. Dangas, any thoughts on your end?
No, as little as possible. If we just have them overlap by a couple of millimeters would be great, but it's very difficult to achieve that practically because of this stiff deployment pattern, but we'll see.
What about you, Dr. Burkett?
Same thing. I think 1 centimeter maximum overlap.
Right.
What you want to avoid is a gap in between the two, because the last thing you want is a restenosis in between the two stents. But I think under a centimeter would be good.
That's great.
And I think it's, one point that bears mentioning is the only reason that this is a stiff deploy is because of the advantage of the PTX. So the PTX makes this a tougher stent to deploy on this iteration, and as you mentioned, this is being addressed by the manufacturer in order to make it easier to deploy.
I think being first to market presents a lot of challenges, as I'm sure you've discussed with them. And I think part of it is, you come out with the best product that you can and get it into operators' hands all across different skill levels, et cetera. And then you learn what are the things that matter. And I think they've clearly seen, especially during the trial, that this particular one. Now, is that considered a good level, or would you go in further?
If you could drop it right there, that'd be great. What I tend to do is go forward about a centimeter or so, and then start to do the deploy. As soon as I see a little bit of flour, then I pull it back.
I think that's an important point for everybody at home, because I know we have all different skill levels and areas of expertise watching. And I think what Dr. Burkett's point is that that this stent is going to move forward, is not going to deploy on a dime. So what you would like to do is give yourself a margin for error. And so what we did here was we went in a little further than we needed to, and hopefully I can flour it and then bring it back. And then so what I'm going to do here is I'm just going to, again, it's quite stiff, so I'm just going to go very slow, okay? And then see, it's already starting to come back, as you can see, which is actually acceptable there. So, so there it actually helped me, this particular technique of what we talked about. So now again, it jumped forward, whoops, and look what happened there. So that happens, and don't be distressed when that kind of stuff happens. Do it slowly, do it under fluoroscopy guidance, and then adjust it. Any worries about elongating this stent, Dr. Burkett? Any worries about elongating this stent?
I don't think with this particular deployment system and this particular stent, I think if you are reasonably careful, you're not going to have significant elongation. But I think
can pull it back a little bit now. That's great. Exactly now. Excellent.
Oh, Dr. Dangas, I tell you, the deployment system is great, but it is a little stiff, as you see, and I probably was more than I wanted to be there. But at the same time, I'm happy that I'm able to get adequate overlap. And here, and you can see how the vessel prep has really helped us.
Yeah.
We were able to really expand the stent very nicely, and you can see by also looking at it under fluoroscopy, the actual dimensions of the diamonds are not stretched. Yeah. And I know that's an important point, especially if you use a different sort of stent. The slotted stent design stent basically has that issue with that, where if you actually stretch it, the early data actually shows that you have a higher restenosis rate. So I think part of what we're learning as we're using multiple stents is about how to deploy them, how to size them, and I think we're learning quite a bit on this particular field. So I'm just going to do a little roadmap, and then this is where the real question and expertise I think comes, and I'm glad I have you guys, because the question is, how far are you going to cover here? So you're going to have to put another 100 in, but are you going to go all the way up to the ostium, or what are we going to do here?
So I think clearly you have to use 100 at this point because you can see that's where you started working,
Right.
and then you've got the proximal dissection.
Yeah.
So put in 100 and see.
So, as
700,
far as
guys?
possible.
So I think one of the points that you were talking about, PK, which I think is,
Might be in my office. Is that one in my office? Okay, we're going to get a 70100.
that'd be great.
So this way we'll do it.
One of the
open.
points I wanted to make, PK, that I think is really important, you were asking about elongation with this stent. With some stents, some even nitinol tube stents, you can have quite a bit of elongation. And so a lot of times what I'll do is I'll start to deploy the stent, kind of get that distal anchor, that distal flower, and then I no longer pay any attention to the distal end or the deployment location. I'll shift the image intensifier so that I can see the proximal end, and then I just keep it stationary. Otherwise, you can inadvertently start stretching that stent or compressing that stent, and I think that leads to worse outcomes. And also, if you shorten it, then you may end up dropping in two stents where
stents.
one would have done it.
I think that's a great point. I think these are the techniques and things that we learn from each other. I think that's an awesome point in terms of how to land it. But my question, Dr. Burkett, is I know you've done incredible amounts of work in the cost of what we're doing here and what we all do in our practices. So we know this is an expensive stent, and there's no reason to talk about the price. It's more expensive than a regular stent. So what do you think in today's day and age, spending extra money on better technology, better results? Of course, the patient is always number one, but is there an algorithm that you use to make your decision on who should get a drug-eluting stent versus a non-drug-eluting stent?
Well, that's exactly what you said. If the patient is number one, then that defines the strategy very well. Another way of looking at it is kind of the golden rule. If this were you on the table,
right,
what would you want? And what I would want is the most durable result, pretty much regardless of cost. And so that, I think, is where the beauty of the paclitaxel-coated stent comes in, because if you look at the cost data, the initial procedure, no question, will be more expensive.
Yes.
If we put bare nitinol in here, this would be a cheaper procedure.
Absolutely.
If we did just balloon and kind of hope for the best, cheaper procedure. So by putting in PTX, it drives the cost of the initial procedure up, but it cuts the chance of a TLR, target lesion revascularization, is going to be dropped about 45%. That second procedure is going to be so expensive that all of a sudden the cost of this is offset.
Exactly. I think that's a great point that Dr. Burkett makes, and I think it's important for we all. I'd just like to add one thing to that. Can you get that, please? One thing to that. One is, very, very simply put, remember, when you bring the patient back, you're going to give more dye. There's more radiation. There's more chance of growing complications. There's more chance of dissection, more chance of iliac issues. There's so many other things that can go wrong to this particular patient beyond just the TLR that we're dealing with. So first and foremost, in this kind of patient who has a little bit of elevated creatinine, not crazy, but clearly multiple procedures may make that an issue. And the second is, the point is that the repeat procedures are going to be reduced. So therefore, I think I agree with you, Dr. Burkett. I think I'm a convert now. Into using this technology early on rather than later on, and I think hopefully so far in our anecdotal Mount Sinai number that we've done so far, we're very happy with our results. But this is a question I throw out to a lot of people, and I'm glad that you were able to answer that question for me. George, any thoughts on you on the financial aspects of this?
Well, I think one could identify patients at high risk for restenosis with the longer lesions and obviously the diabetic and all that. But at the same time, these are the patients that you need more stents because you don't have long stents beyond the 100 at this point. I guess you're paying more, but you're also going to gain more in the end by saving a restenosis.
But George, I have a great question. I think you brought up a beautiful point there. So yep, that's perfect. So George, if you have a patient with, say, a 30 millimeter lesion, Dr. Burkett, for both of you, and now as we know, the bare metal patencies or the self-expanding patencies are pretty acceptable in that particular range. So at that case, would you say to yourself, hey, you know what, I am going to go ahead and use a bare metal stent here, have cost savings, or would you also say in this particular lesion, I'm still going to use a drug-eluting technology if the stent size is available?
Great. So with a short lesion, I'm going to try to get by with a balloon. And I realize that some randomized data would support the use of a stent simply to decrease the chance of TLR. However, if you have a TLR after a balloon result in a 30 or 40 millimeter lesion, that's going to be pretty easy to treat. if you have in-stent restenosis, whether it's short or long, it's still kind of a complicated treatment. So I'm probably going to go with balloon only if I can get away with it.
Right.
And
What
looks
about
like
you,
we got
George?
a great proximal result over here.
Well, the question here is, I think this is why I took this picture, because I wanted to first pick both of your minds on this, and Dr. Wiley. Would you now have to treat this proximal disease with stents, or would you deem it non-obstructive? That's one, by angiogram. Number two, would you do a pullback gradient with an end-hole catheter and see if there's a gradient? I know it hasn't been validated. I want to bring that up because, how do you assess the severity of this proximal disease? Or do you say, hey, I've gotten rid of the occlusion, I'm certain, I haven't taken a picture yet, I'm certain I have reasonable runoff down to the foot. Let me see how he does. Let me stop here. Let me cut my losses.
I agree with that. I would post-dilate all the stents and be very happy with this result.
Dr. Wiley?
I agree. I think that at most there's perhaps 50% stenosis there. I mean, you could always do a pullback gradient, but I think that avoiding more stents would be a reasonable approach.
I'd like to avoid stents. Now, I don't think, did you ever have the 6 millimeter all the way up to the origin of the SFA?
Never.
Okay.
This is where we ended. We've covered the ballooned area.
Yeah, so I may eat my words and really regret that I recommended this, but on the other hand, I'd like to see just that little proximal area about 1 centimeter into the SFA concerns me just enough that I might try a gentle balloon inflation there. Favorable characteristics include absence of calcification and it's concentric. So the chance of a decent balloon result, if we don't get overly aggressive, is pretty good. So I might do balloon only. Now, obviously, if you get a bad dissection, then you've just bought a stent. So
exactly.
That could really be a wrong choice.
But the question is, what is the value? How can we evaluate this in the cardiac cath lab? We know with the coronaries, we're lucky enough to do a pressure wire. We're able to do that, and we're able to say, FFR and say this is significant, this is not significant. So here you have a lesion, which is like angiographically, you can tell it's very difficult to judge. So is there a value for a gradient here?
I think there is. Again, virtually no data that would support that. But what we would typically do is, if we've used a crossing catheter already, it's already been opened up, just drop that down distally, hook it up with a pressure gradient. Ideally, if you had 2 transducers, you could see what the gradient is. Slowly pull back, and if there's an abrupt step up, then that tells you, yeah, it probably needs to be treated. On the other hand, if it kind of gradually decreases from the stented area up to the common femoral, maybe there's no benefit.
No benefit. That's a great point. So what do you guys suggest? I'm going to leave it to a vote. George?
Post-dilate the stents and be happy.
Jose?
I agree.
Post-dilate?
Post-dilate then.
And Dr. Burkett's already said what he was going to say. So what I'm going to do here is I'm going to do a gradient. Give me a straight catheter. We've got 5 more minutes.
But I think you should post-dilate first and then do the gradient.
Well, I'm not going to go into the stents here, George. I'm just going to go distal to that proximal lesion that Dr. Burkett was concerned with. And I think I share his concern there. And I think the treatment point here may actually surprise us. So obviously we don't have time to set up 2 transducers here to be totally elegant. But what I will do is do a slow pullback and see where we're at. So,
you know what, Prakash, I think would be interesting to discuss, and I'd like to listen to Dr. Burkett's insight on this. Years ago, with the Sirocco trial, that sirolimus was used, the trial actually failed. And now with a different drug, the results seem to be much more robust and better. Do you think this is all because of the drug choice or the stent that was used, or?
I think it's because of the drug, but that's an incredible question. It's like why is it that sirolimus does so well in the coronaries? Because we know that sirolimus-coated coronary stents did just fine. The ones that were commercially available, a little tough to deploy, but once they were in, the results were pretty good. So why is it that it was a complete failure in the SFA? My guess is it's the drug, but that's a question that I don't really have a definite answer for.
George, any thoughts on that?
No, not really.
Well, I just wanted to add and see what Dr. Burkett had to say. Could it have been a dosing issue? Could that have been the reason why this happened? Or do you think it's truly just a drug characteristic here?
I think maybe also there's a component of the dosing issue.
So guys, we have a resting gradient, a resting pressure of 140. 148, 149. Can you show the monitor, guys, so everybody can see? And so what I'm going to do is just do, it's a poor man's pullback here, and to save money, like we talked about, to be fiscally responsible as much as we can. And we're just doing a very gentle pull back across, and you can see by watching the pressure gradient and see whether we have a sudden spike. So it's at 151 here, and now I'm going to go proximal.
Just the pressure alone tells you that there's not bad disease proximal, and it's very comparable to what kind of pressure you were running before.
So it's basically around 153, so about a 5 millimeter gradient. Now I'm in the common femoral, obviously, and obviously it's a little bit bigger vessel there. So it's about 160, so anywhere from, if you go all the way up to the ostium, you have a 10 millimeter resting gradient. Any thoughts now? Does that change anybody's mind?
No.
It makes me a little more comfortable with leaving that alone.
Yep, and I think I will at this stage. We'll leave it alone, and obviously he's our patient and he's part of our system. So what we'll do is we'll post-dilate this offline, do our runoffs, and for the sake of time, and we're probably going to end up here. Let me just take one shot of the distal runoff before I leave it to our team to post-dilate, and then Dr. Burkett is kind enough to share a lecture with us on the drug-eluting technology in the SFA, especially with reference to the particular stent that we've just used. So that will be archived for our audience, and you're obviously welcome to come back and watch that. So, whoops, it's attached to this. Pardon me. So let me take this out here. So therefore, I'm gonna go ahead and just take one picture. And in the meantime, thank Dr. Burkett so much for taking so much time out of his busy schedule. I know he, being the chairman there, is very busy. I really appreciate you coming down, Dr. Burkett, and helping us.
Thanks for having me, PK. Yeah, it's been great to be able to work with your team right here in your lab.
And and Dr. Wiley, again, thank you for your input. And Dr. Dangas, thank you very, very much.
I think we're a great case over here, PK, and a great crossing, and I think the use of the drug-eluting stents was very appropriate, and the demonstration very telling.
Yep. So what we'll do is we'll go ahead and do a recap in a second after Dr. Burkett's lecture, and I think really I think this is a case that really brought up a lot of discussion points, not only on crossing lesions, but how to deploy the stent, the actual science behind the stent, and some physiologic evaluation as well as anatomic evaluation with intravascular ultrasound, as well as with pressure gradients, which, as we talked about, have yet to be truly validated. But I again thank you again, everyone. I thank Elizabeth. I thank Ricky, our AV team, Dr. Burkett again, Ray and Jose. Thank you again. And we'll see you guys in April.
Thanks thank to entire Cath Lab team. And before we move on with the lecture, let me remind everybody that the next webcast is going to be on April 16th. The same time is again on Wednesday. Again, April 16th, the next endovascular webcast, just a day after the next coronary webcast, which is going to be on April 15th. I would also like to let everybody know that you can view the previous webcasts in the archive function of this website, and where you will be able to view this entire case if you have joined from the middle, if you have missed some parts of it. In just a few days. And again, all the previous webcast cases are available in the archives, and you could also continue to submit questions such as those that I discussed over the course of today's presentation. I brought them up to the attention of the operators. The similar way, you could also answer questions, and we'll answer them. You would ask questions, and we'll answer them at the blog. I would also like to let you know that we have a live conference of coronary and endovascular live cases, as well as structural live cases here at Mount Sinai in June 2014 in the premises of the Medical Center in New York City. And the dates are June 10 to 14. And we would be happy if you would be able to come in person and meet us and view the cases and listen to the lectures, and the website is available for registration right now in the complex coronary vascular and structural cases, June 10 until June 13, 2014. And again, thank you for watching today's webcast. Goodbye from New York.